Hello to you all and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. This is the Pharmacology series of videos, and today we're going to take a look at the drugs for nervous and hormonal pathologies. So let's begin. So interactions in nervous and hormonal system pathologies. Starting with the thyroid. The main pathology here is the hypothyroidism, and it can be autoimmune or triggered by some factors. 5% of the population has it, and the majority of the times is related with iodine deficiency, and Spain is an iodine deficient country. So how the thyroid works? There is the TRH released by the hypothalamus. It reaches the pituitary gland, and the pituitary gland creates the TSH. The TSH then goes to the thyroid gland, and there is an iodination and a tyrosine binding, creating the T4 and T3 thyroid hormones, and their action is to increase the metabolism. Knowing that, we have three types of hypothyroidism. The primary hypothyroidism, where there is a thyroid gland abnormality. The secondary hypothyroidism, when there is a reduced TSH secretion from the pituitary gland. And the tertiary, when affecting the TRH and the hypothalamus. Knowing that, the hypothyroidism, we have the levothyroxine to treat it. It is a synthetic analog of the T4 hormone, and it normalizes the deficiency. It can be taken orally or parenterally and taken whole with a little water in the morning on an empty stomach, 30 minutes before breakfast. Not recommended in Addison's disease or acute myocardial infarction. It may cause symptoms of hyperthyroidism, so a lot of activity and increased metabolism and more energy expenditure overall. It interacts with fiber, milk, coffee, juices, papaya, calcium, iron, and chromium, lowering the T4 levels. The soy will increase the TSH, and the vitamin C will increase the T3 and T4 and lowering the TSH. On the other hand, we have the hyperthyroidism. Here we have the carbimazole, methimazole, and thiamazole. They are antithyroid drugs, and they inhibit the iodine oxidation by inhibiting the peroxidases. They are taken orally, with liquid, with or without food. They are effective after 2 weeks and can be stopped after 2 years. So they can maybe not be chronic, because the hypothyroidism is chronic. The hyper maybe not. They cause liver toxicity, agranulocytosis, neutropenia, and thrombocytopenia. Then iodine and radioactive iodine. Giving extra iodine may be beneficial in the short term, because an excess of it inhibits the iodine uptake by the thyroid, and if it is radioactive, it destroys the thyroid. But the hypothyroidism will return in a few weeks, so it's a limited utility. It may cause hypersensitivity reactions, angioedema, skin allergies, and serum sickness. Moving on, we have the mood disorders. Depression. Depression is a mood without interest or pleasure. When we have low energy, it lasts for 2 weeks minimum. It is present and unrelated to previous events, and may be due to thyroid disorders, medication, and narcotic drugs. Here we can have a depressive disorder, when there is sadness only, or a bipolar depressive disorder, where we have sadness and mania. It may be mild or severe, and when it is severe, it will lead to incapacitation of daily habits. And there are a lot of suicides when it is severe. The non-pharmacological treatment are two mainly. The first one is the cognitive behavioral psychotherapy treatment. This is what the psychologist, psychiatrists treats, and it is the most effective. The majority of the times it is prescribed in combination with some drugs. And then there is also this other treatment, the electroconvulsive therapy, which is epileptic seizures with a central nervous system stimulation. And this treatment is controversial, not well accepted by everyone. So what are the drugs? Drugs can be for acute, continuation, or maintenance treatment. We have the selective serotonin reuptake inhibitors, escitalopram, fluoxetine, paroxetine. They selectively inhibit the reuptake of serotonin by neural presynaptic membrane, increasing the serotonin to the central nervous system. They are taken orally, with or without food, with liquid. They may cause nausea, dry mouth, sedation, and constipation, the paroxetine mainly. Weight loss, the fluoxetine, and weight gain, the paroxetine. So I guess it's better not to take the paroxetine. Grapefruit juice will increase the toxicity because of the cytochrome P450, and the tryptophan will give us a serotoninergic syndrome. The hyperic will increase the effect and the toxicity because of the cytochrome P450, and the alcohol will give central nervous system depression. Then there is the serotoninergic antagonist antidepressant, the vortioxetine. It is a modulator of serotoninergic transmission and inhibitor of serotonin transporters. It is taken orally with or without food, with liquid, decreases the risk of relapse and may cause nausea and vomiting. And then we have the serotonin and noradrenaline reuptake inhibitors, if these are not enough. Here we have the duloxetine mainly, and this is taken orally with liquid, with or without food. There is a lower absorption of duloxetine when taken with food, and the venlafaxine will increase the Cmax when taken with fat. Tryptophan will give us a serotonergic syndrome, and alcohol a central nervous system depression. Alprazolam and alcohol will give us a higher aggression, so the patient starts to become aggressive. The diazepam with alcohol will increase the effects, caffeine will lower the effects, and the grapefruit juice will increase the effects and the toxicity because of the cytochrome P450. Then we have the tricyclic antidepressants, the amitriptyline, and this is for major depressive episodes. It is taken orally with liquid, with or without food, at night. Non-specific, and it has many adverse reactions. It gives sedation and drowsiness. That's why we take it at night. Fiber will lower its absorption, and the DIO enzyme will interact with histamine-rich foods. Hypericum will increase the effects and toxicity. Alcohol will increase the central nervous system depressant effect. And then we have the serotonergic receptor antagonist and serotonin uptake inhibitors. So a combination of the first two, which are the mirtazapine and trazodone. They have an antiemetic effect for oncology patient, and they are taken orally with liquid, with or without food, at night. They give us dry mouth, drowsiness and sedation. That's why they are taken at night. And on the other hand, we have anxiety. It is related to the survival of the species, and it is an anticipation of future harm or misfortune, the fear of any situation with an insecurity. The symptoms are edginess, restlessness, irritability, difficulty concentrating, difficulty sleeping, muscle tension, and chronic fatigue. And this will give us the generalized anxiety disorder, which is excessive, more than someone else, persistent, doesn't go away, and unreasonable, shouldn't be worried. For the diagnosis of anxiety, there is the DSM-5. Drugs for the anxiety, we use the benzodiazepines. Here we have the diazepam, Valium, alprazolam, Xanax, clonazepam, Klonopin, and lorazepam, anxiolytic and hypnotic. They calm or sedate by raising the level of the inhibitory neurotransmitter GABA in the brain. The way of taking it is rectal or injectable solution, for example the diazepam, and oral with liquid, with or without food, the alprazolam, the Xanax. We have to give the lowest possible dose that is effective. The treatment should not exceed the 4 to 6 months, and we have to reduce the dose progressively, because these drugs are prescribed together with antidepressants. So we start with the benzodiazepines very high, and with the antidepressants low. And as we progress, this has to equal and then reverse. So we have to lower the benzodiazepines and increase the antidepressants. They have an interaction with grapefruit juice, increasing their effect because of the cytochrome P450. Caffeine will lower their effect, ethanol will increase the effect, and an interaction between alprazolam, Xanax and alcohol gives an increased aggressiveness. And now it's time to talk about diabetes. So I have already done many videos talking about diabetes, where I explain the definition, the types, the physiopathology, and especially the non-pharmacological treatment. So now it's time to see what is the pharmacological treatment, starting with the increased insulin sensitivity. Here we have the metformin, which is the most common one. It is a biguanide and it acts at 3 levels: liver, muscle and intestine. It improves the lipid profile and weight reduction. Taken orally, decreases the hemoglobin A1C by 1.5 to 2%, and it has a delayed absorption with food. It increases the absorption of vitamin D, it increases the effects with the vitamin A, C and E, as well as with prebiotics and alcohol, fiber and spirulina. The plantago vata improves the glycemia, but the metformin will lower the absorption of vitamin B12. So be careful with that. On the other hand, we have the pioglitazone. It is a thiazolidinedione, and it may lead to weight gain. It decreases the hemoglobin A1C by 1 to 1.6%, and it is taken oral with or without food, better on an empty stomach. Be careful with bioflavonoids in the grapefruit juice because they increase the hypoglycemic effect, and the treatment lasts 6 to 8 weeks until improvement. This is why we prescribe a lot more metformin than pioglitazone, especially because metformin promotes a weight reduction and pioglitazone a weight gain. Then we have the increased insulin secretion. So here's sensitivity, here's secretion. We have the glibenclamide, which decreases the hemoglobin A1C by 1 to 1.8%, taken orally, with or without food, shortly before or during the meals. There is a risk of hypoglycemia, and there are some interactions. Fiber decreases the bioavailability. The plantago vata improves the hypoglycemic effect and the metabolic control, and they are used together to improve the glycemia. Then we have the repaglinide. Decreases the hemoglobin A1C by 1.5 to 2%, taken orally, with or without food. It is recommended to take 15 to 30 minutes before a meal. It can be administered 3 times a day, and the effects last for about 6 hours. There is a risk of hypoglycemia because it's forcing insulin secretion. And then we have the sitagliptin. It decreases the hemoglobin A1C by 0.6 to 0.8, taken orally, with or without food, and it does not have an hypoglycemia or pancreatic depletion. Usually used in combination with metformin as a second step, and the flavonoids, the grapefruit juice, will increase the effect. Then we have the ones that reduce the digestive absorption of glucose, the acarbose, which will lower the hemoglobin A1C less than 1%. It is taken orally, always with food, because we are going to reduce the digested glucose, so when we eat, and they do not produce hypoglycemia, as they do not affect the insulin. It can cause diarrhea, very frequent, and low vitamin K and B12 absorption. The flavonoid will increase the effects. And here we also have the guar that also reduces the digestive absorption of glucose. Then we have the inhibition of renal tissue reabsorption of glucose. Here there is the dapagliflozin. Hypoglycemic effects depend on the renal status because they work by blocking the reabsorption of glucose in the nephron. They lower the hemoglobin A1C from 0.7 to 1.1%, taken orally, with or without food, and not prescribed in diabetes mellitus type 1. And we have to monitor the patient's hydration, increases the diuresis and the urinary glucose excretion. And then last but not least, we have the GLP-1, glucagon-like peptide 1. This is the semaglutide. It helps the pancreas to secrete the correct dose of insulin when there is an hyperglycemia. This is the Ozempic. It decreases the hemoglobin A1C from 1.5 to 2%. It is taken orally 30 minutes before ingesting food or drugs to improve their bioavailability, because alone they have a poor absorption. Not prescribed for diabetes mellitus type 1, and we have to monitor the patient's hydration and introduce gradually to avoid the digestive discomfort. They are used mainly in diabetes type 2, and it goes together with another hypoglycemic agent. The majority of the times is metformin. Okay, that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download this diagram by clicking the first link in the description. Don't forget to like, subscribe, and share this video to your friends and family if you found it helpful. Thank you so much for watching, and I will see you in the next one. Ciao! Hope you enjoy it.